EUS.
Yeah.
Okay, well, that's a slightly longer question, so we'll cover it up during the course, but I will address that. Before, Khalid, can you hear me? Khalid?
I can hear you.
Okay, we can hear you and we can see you.
Okay, so do you have me on the screen? You have a EUS and you have a endoscopic picture, right?
At the moment, we only have you because the endoscopic picture is not there. So, yes, now we have endoscopic picture and we have a small EUS for now.
Okay.
But we can shift to large EUS or endoscopy depending on what you do.
But now you have me as well with those?
Yes.
Okay, perfect. Okay.
So now we have your screen and you both.
Okay. So we're going to go ahead and present the case first, and then I want to go over the scope a little bit, and intubation and how to start and everything. How much time I have?
Well, for normally you take about 30 seconds to do the case, but I would request you to take a little bit of time.
No, I'm going to take some time. It's going to be 20 minutes or so.
Yeah, we'll give you half an hour for the case if that's
perfect.
Okay.
That's perfect. So we'll go ahead and present the case first and then go from there.
So our patient is a 21-year-old male with no known comorbids, presented to us with a complaint of jaundice, pruritus, and weight loss for 8 months. CT scan was done, which showed a well-circumscribed lesion at the confluence of the left and the right main hepatic nephs. Now we'll proceed with the EUS.
So, can you hear me still?
Yes, we can hear you.
Okay. So I think we'll take a look at the, that area as well, but I think the whole goal is going to be do the whole EUS and show all the steps. So obviously first you do is whenever you start the procedure, just make sure the equipment is functional and it's working. So we have checked it, the air is working, water is working. On the linear, many people may not put a balloon on the transducer. I prefer that, and I think they know that, so they already put that. One of the reasons I prefer that is especially if I'm in a D2 or I'm in an area where I'm not able to get rid of all the air or air bubbles, I have something to fall back on, and I put the water in the balloon to approximate to the wall or opposed to the wall. So that's why I prefer that. But you don't need a balloon on the linear if you don't want. So here, do you have a comment?
No, I normally, just to look at the structures, it's not a problem. Very rarely you need to use the balloon. But what Khalid is trying to say is the use of balloon is that sometimes you have air which you're not getting rid of. So you inflate the balloon and you deflate the balloon, and in that process, once you inflate it and try and aspirate air out, you can get rid of that, and mostly that. And some people use it in the bulb also when they inflate the balloon, and if they can't get structures, well, they can use. But by and large, you don't need balloons for EUS.
Okay.
Right, sir?
Yes. So here is the scope itself. The way I hold the scope is, if you look at my fingers, they are at close to 25. So upper esophageal sphincter is majority of the time between 17, 19 centimeter from the lips or incisors. So a lot of people, sometimes what they do it, either they are holding it too close to the transducer. So you go in, by the time you get to the oropharyngeal area and patient is coughing, not well sedated, and you're struggling to intubate the upper esophageal sphincter, and then you have to move your hand back as well, and you're giving more time, and then you have to pull the scope out. So what I suggest is have enough scope that you are able to at least pass 4 or 5 centimeter below the upper esophageal sphincter. If you are too far, then you lose control of the scope. So you have to be at enough length that you don't lose the control of the scope, and also have enough space to be below the upper esophageal sphincter. Other thing is, the way I put the hold the scope is, I call this a neutral position of the scope. If you look at the umbilical cord, what we call of the scope, and the transducer itself, if you put the scope on a table, they both are opposite to each other. One is in the other direction, other is in the opposite direction. So the way I'm holding the scope, or the way I hold the scope, for me, the neutral position of the scope is the scope handle is resting on my palm, wheels are facing upwards, and the transducer of the scope when I go in is towards the anterior of the patient. So that's how I hold the scope. We're going to go ahead and turn the other thing, one more thing before I go in. I look at the this bending of the scope. Mustafa already explained about that, how much scope you have beyond the bend, and what is the diameter of the scope itself. It's a pretty big scope, so you have to be careful about that. And usually transducer is small, but the thickness is really behind that 3 centimeter or so from the transducer, 2 to 3 centimeter. One thing, what we do is like I have a different way of intubating. You can follow whatever way works for you. Majority of the people, when they go into the patient, they go in like this, and then they go over the tongue. What I do is, if you look at my wrist, I'm going to rotate it a little bit, and I make it upside down. That's just the way I do it. Have you seen an oral airway? Have you done an oral airway that looks like this? You always flip it, go above the tongue, and then you flip it back. I use the same principle with the scope as well, and I do that without even thinking. I do that with the EGD scope too, so that way the tongue does not come in my way. When I have the scope transducer right behind the tongue in the oropharyngeal area, I just flip it back, and it just goes straight into the upper esophageal sphincter area and into the esophagus. So I'll try to demonstrate that the way I do. I turn the light on now. You see the scope. I'm going to go in. If you look at that, it looks like an upside down. I'm going in straight. Now the scope is still straight. As soon as I hit the back of the throat, I flip my scope. And when I flip it, even without looking, I'm moving the scope very gently, and you're going to see that it just passes very gently beyond, like at the upper esophageal sphincter. Other thing which I don't know if you noticed that or not, I was doing this movement with my wrist. If you see that, this one, so that kind of opens up the upper esophageal sphincter, and also they feel like they have to swallow something in the back of the throat, and then they swallow that. Next time you get into the esophagus, don't go crazy from there and just start pushing the scope. You should have some endoscopic view, because some of these patients may have a stricture and you don't want to push through that. Right now I'm in the esophagus. Camera is at 45 angle. I'm gently moving the scope. I can see the scope there. I see the scope, it's moving in there. Gently moving in there. I'm moving the scope very gently. This is very important. Look at that. Now I'm right at the GE junction. My scope, I'm stepping back from the patient, trying to keep the scope straight. If you go, can we make a EUS? First thing I'm going to go is I'm going to go towards the opposite. Right now I'm at 42 centimeter at the GE junction. From 42, if I move like 7 to 8 centimeter, that will take me to the opposite wall of the stomach. When I get there, I'm going to suction, move big wheel towards me, and rotate the scope a little bit to the right. So can we switch it to the EUS image now, please? Yeah. You see that I went to the left lobe of the liver. If you look at the transducer, there's a little bit air in the balloon. So what I'm going to do is, you see that? How that air disappeared by just inflating the balloon a little bit. Right now, my scope is still straight. I got the left lobe of the liver. After I get that, my goal is to bring the liver right underneath the transducer. So I'm going to bring that back a little bit, pulling the scope back. When the liver is right underneath the transducer, somebody noticed something in the liver? What do you see? Anybody wants to comment? Anything unusual, usual?
They say a biliary dilatation.
Yes, exactly. That's why I put a Doppler on there. So this is, I'm looking at the liver, I'm thinking, okay, there is some problem somewhere there. There is, here is clinical presentation, and looking at the liver, intrahepatic ductal dilation, so there is some obstruction at some level. But anyway, so right now, I'm like my scope is really, really straight. I pull the scope back a little bit. Liver is right underneath the transducer, and I'm going to put a little bit water. You don't have to go crazy on that in the balloon. You can see the liver is there. Now from earlier I was at 180. From there, I'm going to pull the scope back a little bit. I'm rotating to the right, my scope. So if I want to take a look at IVC, you can see that IVC right there going into the right atrium, but that's not what I'm interested. So I'm going to go a little bit further to the right from there and find my aorta. You see that? From 80, I came up pretty much all the way to 90 degrees. You look at the aorta. Aorta is kind of falling nicely downwards. I follow the aorta, trying to keep that underneath the transducer, doing a little bit right and left. My goal is to look for celiac. You see right here?
Okay, let me.
Right there is the celiac right there. This is a diaphragm right above that. That's the diaphragm you see right here, this blue structure. Aorta, celiac. If I push a little bit further, I may be able to see that SMA. It looks like it's coming underneath. But right now, I'm most interested in the celiac, so I'll pay attention to that. I will bring the celiac right underneath the transducer. Now I will just follow the celiac. When I follow that, sometimes you can see that the left gastric is coming right here. It's a little bit to the right of the screen. So I'm not interested in that. I'm going to just follow the main one. Just follow, and that should take me straight to the pancreas. The only thing I really did is, I'm going to get some water.
Get you some strepsils?
No, I'm good. So if you look at that, when I followed that, sometimes you may lose it, but don't worry about that. You just keep gently pushing the scope in. It's advancing the scope really. Pushing the scope is a kind of not the right term, but advancing the scope. You can see that splenic artery is there, splenic vein is there. If I follow the splenic vein downwards, you can see it's coming down. This is SMV, they're getting together, they're making the portal vein. Portal vein is down right now here, and it's going downwards. If I follow it downwards right here, I can follow that to the liver really. If I keep rotating it and bringing it down, it will take me to the liver. But right now, let's pay attention just to the pancreas. So the pancreas is right
so
here.
Khalid, now that you've got the pancreas and the splenic vessels, are you going to go, what happens when you go clockwise and what happens when you go anti-clockwise?
So that's what I'm gonna do that right now. That's where I was coming to. So here, this pancreas, if you look at it, you see that the pancreas itself, there are like foci and strands. That's a pretty normal looking pancreas in Asians. But if in Westerns, that could be a sign of early chronic pancreatitis. Other thing, if you look at me, my right hand is really, I'm using it to control the keyboard and whatever accessories I have to use. If my scope really is in the right position, scope is really straight, the only time I really have to use the right hand is just to push the scope in, pull it out, and while using the accessories. So here, I'm going to keep, I don't see the duct really very well here, and which is okay. It's a very small duct probably. So probably very small duct. What I'm going to do is I'm going to rotate the scope to the right, rotating it to the right. What I'm trying to do is go towards the tail of the pancreas. So keeping the pancreas right underneath the transducer, right underneath the transducer. If you look here, I see a structure coming. So that's the left kidney. So the first thing which is going to come is the left kidney, but I still see the pancreas. I haven't seen the spleen. So I'm going to keep pulling the scope back. You see the pancreas right here. Keep pulling the scope back a little bit, rotating it to the right. And now you see that the pancreas is kind of falling in down there. That's the tail of the pancreas. And the spleen is right here. So sometimes if you don't see a lesion in the tail of the pancreas, you really are not looking at that. So here the tail ends right here. Nice and beautiful looking pancreas, spleen here, pancreas there, and left kidney there. So you have a question?
Khalid, I know you're having problems with your throat, but from where you were, the station, all you did was moved clockwise?
Yeah. So pull the scope back a little bit and move it clockwise. So I kept pulling. And other thing is sometimes you don't really always have to pull the scope back.
Yeah.
Sometimes you really may have to push a little bit or rotate right or left. The main goal is whatever structure you are looking at is keep that right underneath the transducer.
So to keep the structure right underneath the transducer, all you need to do is advance the scope if you want to move along with it or pull back. And then obviously just use the clockwise. So you only have 4 movements here. You have anti-clock, clock, and you have advancement or a little bit of pullback. But what we are talking about here is, like Khalid said, is just literally millimeters. You're not talking about major movements here at all. The moment you make a big move, you've lost everything. I just took over while you were having water.
Okay, thank you. So and other thing is it's a very, very controlled movement, right and left. If you see that, I'm not even using right hand.
We just saw the pancreatic duct.
Yeah, yeah, we did. I think that's a vessel. That's not a pancreatic duct. Let's see. You see that?
There's a smaller vessel.
Yeah, it's the duct is right here. This is duct right there. Okay. Now you see that duct right there. Okay. So now what I did is I went to go towards the tail and distal body. I rotated the scope to the right and pulled the scope back. Now what I'm going to do is I'm going to do the opposite of that to go towards the neck of the pancreas. Here I see the duct is right there. This is some vessel, but I'm going to follow the duct. I'm going to rotate to the right, to the left a little bit while keeping the duct right underneath the transducer. And you see that how the duct is falling into the neck of the pancreas right here? That's a nice looking neck of the pancreas right there. I don't see any further pancreas, but here, other thing is, I'm going to put a Doppler here. आप थोड़ा सा नीचे हो जाओगे. You see a structure right on the opposite side of the portal vein right there? That's where the bile duct is. You see it right underneath.
We saw it a clearer view just a little while ago, but
yeah. Portal vein right there. Right here, it comes a little bit right there. That's the area of the bile. That's the bile duct. Okay. So here, this is a splenic. This is a SNV. There is a portal vein. Bile duct is going to be on the other side of the portal vein. In this view, may not be coming nicely, but right there it comes a little bit and then disappears, which is okay. So here, you're looking at the whole pancreas, pancreatic neck there. You can follow that duct downwards. We saw the neck of the pancreas, we saw the body, we saw the tail of the pancreas, we have seen the portal vein, have seen the bile duct right there. It comes and goes right there. kind of, I think the mass, they said it's close to the porta
Isn't-
hepatis.
It's
If something is right here. I'm sorry, you're going to say something?
no, that's fine. That's what I was.
Right here is the vein. You see the, now you see that the
Okay,
bile duct?
can you just can you just
Yeah,
put the
you see the
cursor on
bile
the
duct,
neck?
right? You see the bile duct right here. That's the bile duct. That
Okay.
small one. It's not dilated in this area. It probably is that something at the hilar area,
Yeah.
which is causing an obstruction right there. That's
Khalid,
the one. G.
They
This is
want
the
you
liver.
to just mark the neck of the pancreas.
So the neck of the pancreas here, when you are at the body of the pancreas, you keep rotating the scope towards the left. When the duct starts coming down this way, earlier when you saw that, I'm going to take the Doppler off for a second.
Remember, clockwise is going to take you there. Anti-clockwise is going to take you there. Clockwise is taking you towards the tail, from the body to the tail. Anti-clock is taking you towards the neck. Okay. So neck is going to come down like this. And you saw the pancreatic duct very nicely coming down.
So this is the, you see the portal confluence here? The pancreas, you see the duct coming down?
Yes, very nicely.
Yeah, right there, that is the area of the neck of the pancreas which is going kind of around the portal confluence. Right there, that's the neck. And also,
Like this, down like this, and that's the neck. And what about the head? Head is going to be from the duodenum. Khalid can see the head from this station sometimes, but I don't even try.
so here we are actually, if I pull the scope back a little bit, you can see the pancreatic body going towards the left, torquing it to the left, and that coming back, and that's getting close there. This all area, you can see the pancreatic duct is coming around that. So this is coming into the proximal head area right in this area. But let's take a look at that from the duodenal bulb. So what I'm going to do is, you have the endoscopic view, I see that. I will keep it like that. I'll go into the pylorus, inflate a little bit, do it under a nice view. So I get into the duodenal bulb. And sometimes these patients which have lesions, you have to keep adjusting yourself a little bit, because the lesions can pull the structures around. So here, if I go in a little bit, I'll get to the duodenal apex.
The big wheel.
Big wheel towards you. And here, when I'm getting to that, what I really did is I adjusted myself a little bit. I have to pull the scope back really. It was not exactly at the duodenal apex. That's another good example, that don't get hung up with one
Khalid,
structure.
can I just request you to have the mic a little bit closer to you? तो आपको ज़्यादा जोर भी नहीं लगाना पड़ेगा.
ठीक है, वहाँ से बढ़ा देंगे, ठीक है, वो उधर से कर देंगे. So here, if you take a look at that, if I go further in, it's a duodenal apex is really, really small on there. So what I'm going to do is I'll stay right at the duodenal apex right here in this area, and from there, as soon as I put my scope on there, big wheel towards me, and I see the pancreas. After I see the pancreas, now I know at least I'm in the pancreas area. Then I do a little bit right and left torquing to really get to my structure. So here, I did a right torque. What it did is brought me to the portal vein. You can see that portal confluence is right here. There is this is an area, I think, of the gallbladder. ठीक है, patient here. ठीक है. So when you see a confluence, I'm going to put a Doppler here. What do you think right here? What is that? Right there.
Looks like stand.
Comes a little bit right there. Do you see any flow in there?
So
What
people
is-
think this is a stent.
Okay, that's what it looks like to me as well. It's clearly a stent in the bile duct. And I did not get that history, but I do see a stent in there clearly, nicely, right there. And when the patient coughs a little bit, it changes the position, which is okay. So here now we have the stent in the bile duct, and I did not see that stent actually maybe from close to the common hepatic duct area. But if I go back into the stomach, I may be able to find it better now. So I'm just rotating the scope right and left in the duodenal bulb, following the stent towards the ampulla, rotating it to the right. From there, and if sometimes you have to just really approximate the scope to the wall. So if I'm going to take the Doppler off for now. If I rotate a little bit right and left, moving the wheel a little bit away from me, and this is all the way to the hilar area right there. You start seeing the portion of the liver right there, and stent, bile duct stent is right there. Bile duct is kind of decompressed possibly. Portal vein is right here. You can see the confluence right there. Portal vein. Here, the other thing is what you need to pay attention to that is this is splenic vein right here, and this is SMV. So they kind of flip when you are looking at those from the D1 as compared to the stomach. Pancreatic duct is right here, and if I do a little bit right and left torque, I may be able to get to the neck of the pancreas. This is the neck of the pancreas right here on the other side of the portal vein.
Perimesenteric vein is coming from this side, splenic vein is coming from here, and then the confluence, and then going towards the liver that side. From stomach, the liver was this side on the right of your screen, whereas when you're in the duodenum, it's reverse.
So here, like to go towards the ampulla. I'm rotating the scope to the right, and I'm getting close to the ampulla. I think it's just because of the lesion itself
There's a
and anatomy
There's a
itself.
lymph node there, Khalid? Just at the, where the stent was, just there?
This is a porta hepatis lymph node, absolutely, right there. You see that? But this does not look like
Malignant.
does not look like a malignant. It
Yeah.
looks more inflammatory lymph node. But anyway, so here, if you look here, this is all the air into the duodenal lumen, and I think that this is the muscularis propria. You can imagine that it's kind of falling down right here, and that's where the ampulla ends right here, and that's a duodenal lumen. So if I gently advance the scope to straighten it, you can see it better right in this area. You see the stent giving a little bit shadowing, but no problem. And rest of the pancreas. This is the duct itself, pancreatic duct right here. He may even have a partial divisum actually. One of the duct branches, you see that duct is going upwards. It kind of crosses above the bile duct. So possibly could have that. And here stent ends. Rest of the pancreas here. I'm going towards the left side now, and right here, if you look at the duct, it's pancreatic duct. It's crossing to the left and taking and going towards the tail of the pancreas. When you look at pancreas from the duodenal bulb, just remember that pancreatic neck is here. Now the pancreas is like this. So head is here, uncinate comes here. Neck is right here around the confluence, portal confluence, and the rest of the pancreas goes here. Pancreatic body is going to be in this area, pancreatic tail is going to be in this area, which obviously we don't see. After I've looked at that portal vein, bile duct, pancreatic duct, all these structures in this area, now I'm going to go into the second part of the duodenum. The other thing is what we do is, like in this case, to take a look at these structures, I really have to come back to the pylorus. to get all those structures. So just remember that all the anatomy is not same, even though all the structures are there, but anatomy may not be the same in every patient. I don't know if you notice that or not. When I go into the D2, what I did was, like, majority of the things I did it in under endoscopic view. It's a little bit different anatomy. What I have to do is I have to rotate the scope a little, quite a bit to the right. Usually you don't have to do that. So once I get into the D2, I'm gonna make the big wheel towards me. I don't see the ampulla, and so I'm gonna rotate right and left so I can get to the aorta. So right, you see that aorta now? Right there. So I did not see the ampulla, so instead of doing that, I used my other second maneuver to find the aorta. From here, I'm standing, I'm moving back a little bit further. If I go torque the scope to the left, let's see what happens. You see the IVC right there? If I go further to the left, you may either see the right kidney or you may see the right lobe of the liver itself. So here, I don't see that, which is, there's something coming up here, which I really, it's okay if you don't see that. So, but aorta, you see, actually the kidney is coming right here. Aorta, IVC, and kidney is in a little bit different position in this patient. Right here, just giving a little bit halo there. But we're not interested in that. What we're gonna do is, I'm just gonna pay attention to the aorta, bring the aorta into the position. From when the aorta comes right in this position, from there I'll torque a little bit to the right further. And if the scope is giving me a little bit trouble, what I'll do is I'll pull the scope back, and now I see that I'm right at the pancreas at least. I see the uncinate process right here. There's a little bit air in there, you see that? That's where I use the balloon. I'm gonna inflate and deflate a little bit to get a better view. Here is the pancreatic duct. Pull the scope back a little bit. It's an unstable position, by the way. It's not a very stable position, which happens sometimes. And here you can see the stent in the bile duct right there. You see that, guys? You see that stent right there? From there, that's a stent. You go a little bit further to the right from there, and you see the PD right there. And you're still crossing the bile duct. So I think he may have a divisum actually.
Okay, this is duodenal humor now. We are in D2. This is the liver. Okay, so this is taking you towards the hilum or towards the liver. This is taking you towards the duodenum. So when you're following, obviously our focus of interest is air. This is your uncinate, and this is the duodenal human. So you've got the ampulla here.
Okay. So here. You see the stent right here, you see the uncinate processes at the bottom, and I'm trying to get to the PD here, I don't see that, then I go a little bit to the right, and there is the PD comes. So it's not close to the bile duct, so he really does have a pancreas divisum right there. You can see that it's opening separately above that, right there. So this is the uncinate process right here.
It's going like this.
Bile duct right there. Pancreatic duct is totally separate from the area of the bile duct and opening separately right there. Once I have that, what I'm going to do is I'm going to make sure all my wheels are unlocked. I'm going to keep the pancreas in my view and slowly start pulling the scope back. Once I fall into the stomach, I would know that. I fell back into the stomach, but pancreas is still there. Pancreas is still there. Pancreas still there. Now I'm getting close to the body. Now you see the left kidney right there, coming back, coming back. Now you see the tail of the pancreas right here. I can adjust the scope a little bit and the spleen here. So you can see that the whole pancreas, starting from the D2, you can come back all the way back and take a look at the whole pancreas in just a few minutes. This was not a very friendly anatomy, just to let you know, especially the duodenal bulb, especially the duodenal aneurysm. So next is actually one more thing before I go there. You see the celiac right here coming off. Usually the way you do is like you bring the celiac right to take a look at the left adrenal. Bring the celiac right underneath the transducer, push the scope in a little bit and rotate to the right, and right here it's coming up right there a little bit, I think. But I don't see that, oh, right there it is. I think this is the left adrenal. It just keeps coming a little bit, but not clear, very clear. There it is. Right there is the left adrenal, right here. You see the left kidney right here? Right above that, there is the left adrenal right there. So the way usually it comes is, majority of the time, when you find the celiac, right there, celiac, bring that underneath the transducer right here, and it's giving aneurysm is giving a little bit trouble to get underneath. Right there it is. After that, you push the scope in a little bit, like 1 to 2 centimeter, and rotate to the right. And if you see the left kidney, and right above that, you might find the adrenal. Right here, left kidney, you see one of the wings of the left adrenal right there, and the rest of the left adrenal is right there. It's like a seagull shape. Okay? So from there, what I'm going to do is, I'll bring that to look at the mediastinum. What I'm going to do is I'll pull the scope back, make the scope in neutral position again, pull the scope back close to 30 or so. When it comes close to that, just a little bit rotation of the scope. You can see that here, I think my balloon is broken, that's what's happening. That's why there's so much air, it's not inflating very well.
खालिद भाई आपसे क्वेश्चन करना था, जो पेशेंट की सीबीडी है वो ठीक लगी आपको स्टेंट के अराउंड उसकी वॉल या?
So no, what you have to understand, when the stent is there, it's looks a little bit thickened, but that could be all because of the stent itself, inflammatory process. I think balloon is broken. We kind of lost the view there completely. ठीक है? I'm not getting any view there of the scope. Suction. I think I can demonstrate that in some other patient. We're having a little trouble here with the patient itself.
Yeah.
So I'll pull the scope out. Oh, you know what? That's another thing. There is no water in the balloon one. That is empty. I see that because when I inflate it, it's just the air coming out. So you have to know the problem. That's what was happening. Every time I thought it's a broken balloon, but there's no water in there for the balloon. उसको fill कर दो मेरे को. बिल्कुल खाली है. इसको fill करके. I think patient is a little bit uncomfortable. What I'm can do is I can do the mediastinum in some other patient. आप लोग ठीक हैं या कर सकते हैं या कर सकते हैं? एक मिनट. अच्छा. वो कह रहे just give him a little bit time and then we can do the mediastinum part.
In our unit, we have daily studies available for 3 days. I know Jazz does it in his unit by himself. They do it themselves. I'm a coward, I like it. So my previously we have we have 3, which is the 3 days that I come. We have daily studies there. And so most of our EUS are done under sedation. And most of the ERCPs that we do are also done under sedation. Except for sedation means
ठीक है?
And
इसका कुछ लाइट के लिए और कुछ लगा दो इसके ऊपर.
all failed cases elsewhere that we do, they are done under protocol. Otherwise, all patients are ERCPs are all done first under sedation. Yeah, liver transplant is complicated ERCPs. All complicated ERCPs are under protocol. और liver transplant में जो stent exchange है वो नहीं करते. We can once we've done the thing so. Khalid,
So,
we are back with you.
Okay, so scope is in a neutral position. I just pull back close to 30 on the scope from the stomach. And when you keep that in the neutral position, a big wheel a little bit towards you, sometimes you have to rotate a little bit to right and left. You see the left atrium comes right here. When the left, you can do a whole echo if you really are interested in that. You can see the mitral valve, you can see the aortic valve right there. But our main, this is the left atrial appendages right there where the vegetations develop. But our goal is to take a look at the subcrina. What I'm going to do is I will bring the left atrium to the left side of the screen. And when I do that, the pulmonary artery appears. So here is the aorta, left atrium, pulmonary artery, and the space between the left atrium and the pulmonary artery is the subcrina. And majority of the times, you can find a lymph node in that, even in a normal situation. You see that? That's a lymph node right there, which is completely normal to find. From here, what I'll do is my wheels are facing upwards. I'm going to make the wheels face downward by rotating it. That takes me to the aorta. When it goes to the aorta, I'm going to pull the scope back. After I get to the aortic arch right here, this is the aortic arch, bring that right underneath the transducer, big wheel towards you a little bit, and then generally push the scope in a little bit and rotate to the right. What that does is that will bring you the pulmonary artery up right there, aorta, pulmonary artery, and this is called AP window. It's really a little bit below that, but this is what we call AP window. From here, if you want to take a look at the further mediastinal structures, you see this is aortic arch, left carotid coming up that, left subclavian is underneath. If I pull it further back, I can, now I'm pretty much into the neck. The best way to take a look at really the thyroid gland is while going in. I'm trying to find if I can find that. Sometimes you can find that on the way out, but majority of the time, oh, there it is. This, you see right there? That's a thyroid gland. Nice looking. I don't see any nodules in that. Looks pretty good right there. So I'm pretty much out of the patient right there. Okay.
From GI to endocrinology. Khalid, so what are you going to, in terms of findings, what do you?
So there is some structure. There was a lymph node in the porta hepatis. The bile duct all the way to the hilum looked okay. I think it's just the stent effect. And something is probably is at the porta hepatis area or the hilar area. And for that, I think the best thing would be take the stent out and put a spyglass there.
Okay. Thank you. Khalid, lymph node we were just going to discuss. Why did you think these were inflammatory lymph nodes rather than malignant or rather than, yeah?
So the main thing when you look at the lymph node, when the lymph node looks black, round, and with no fibrous tissue in that, size also does matter to some extent, but the major features is the shape and echogenicity of the lymph node. The lymph node which we looked at, it appeared triangular. It was kind of a salt and pepper mix. It was not black. It was not round. And there was a fibrous strand in between the lymph node. These are the feature of benign lymph node. And if they're bigger, that's probably because of the inflammation. If, however, I find a really, really round lymph node and it's hypoechogenic, that's the one which I would consider to be a malignant lymph node. I think earlier in presentation when I showed the picture of those anechoic and hypoechoic, the lymph node in that was kind of hypoechoic and very round and well formed. I can show those pictures again.
Okay, great, Khalid. Thank you so much. So we are now going to go into the and